Good morning, everybody. We'll start the first session. Very pleasant morning. All charged up. Let's have an academic feast. Our session is basically manual small incision cataract surgery. My panelists are Dr. Philip Kurula, Dr. NSD Raju, and Dr. Rajesh Shells. Raju sir will be slightly late. We'll start the session. So MSICS, that is manual small incision cataract surgery. Cataract is the leading cause of treatable blindness globally. In India, significant population of mature and hard cataracts are there. MSICS can be performed in any type of cataract with poor resource settings, lesser need for advanced technology, low cost and high volume settings, and the results are comparable with phaco. A brief history, the scleral tunnel incision was introduced in the early 80s. This became the most favored incision technique in the recent past for sutureless small incision non-phaco cataract surgery. Richard Crux in 1983 was the first surgeon to move the cataract incision to sclera from the limbus, and Girard and Hoffman in 1984 were the pioneer to call this incision a sclerotunnel incision. Jack A. Singer in 1991 conducted the first frown incision, which is very common, it is very enthusiastically done by all the cataracts SICS surgeon. And Paul H. Ernst introduced the concept of internal corneal lip, that is a All our speakers had been doing excellent jobs, good surgeons, they all are. Actually my topic is management, some difficult situations. I'll be just showing some videos, some case scenarios to learn something new. So this is a NS 3 to 4 cataract with a moderate dilatation. The surgeon has stained the capsule well, started with the rexus, and the rexus, as we see, it is quite a bit small. Hydrodissection was done, central area is decompressed, well, very good done. And then again, some AC wash, because there was cortex in the AC, some AC wash had been done, so that a clear view of the rexus is seen. Now again, hydrodissection is done very well. The nucleus has hydroprolapsed. She has kept a visco under the nucleus, and she is dialing, and dialing. See what has happened. She had been dialing the nucleus along with the bag. So it was not hydroprolapse that had happened. It was the nucleus with the bag that had prolapsed up. The nucleus is taken out, and the surgery was completed with an iris glow lens. So the take-home message is that adequate size of rexus is very important. You shouldn't judge the rexus by the pupil size, as already been told. You should judge the pupil size, you should do the rexus according to the type of the cataract, and the if you feel that your rexus is small, you can always extend, make it a bit more bigger. Use whatever technique that you can use, like put in gel inside, use a Vanna scissors, make a small nick inside, extend the rexus, or you can go through the side port, make a small nick with a capsulorhexis, micro rexus forceps, and then extend. But your rexus size should be adequate for your nucleus to come out. And the next take-home message is small aliquots of fluid for hydrodissection is very important. You shouldn't just rapidly fill in the bag with the fluid, because it can always lead to capsular block syndrome, capsular bag distension, and can just tear off your PC, and the whole nucleus can go down. So very small aliquots of fluid for hydrodissection is very important. look for the fluid wave. If there is a retroillumination, you can clearly see the fluid wave coming through under the nucleus. Decompress the center, very important. After all the small aliquots of fluid, or after all the micro fluid that goes in, just decompress the center, especially when the cataract is very hard. And don't fish the nucleus in the vitreous cavity. Next one is a traumatic cataract. We can see the corneal sutures. Traumatic cataract is the one type of cataract that can act very weirdly. This is a cataract, very soft intumescent, because the penetrating injury that has just injured the anterior lens capsule, and it has caused an intumescent cortex into the AC. Incision is done, and we can just see that it has just come out through the Simcoe cannula. See, you can see the rexis there. Cortical cleanup is done. The synechiae are released, and the IOL is placed into the bag. Well done surgery. But in traumatic cataracts, you have to think of so many things. That is, the patient should have a B scan to rule out a PC dehiscence, because once the cortex becomes fluffy, you can't see anything behind. You cannot see the cortex or anything. So B scan is a must before the surgery. Presence of intraocular foreign body should be ruled out. The vitreous, how it is, you have to see that. Stain the capsule well, because once the cortex just comes into the AC and it is fluffy, you can't see the rexis, the capsule at all. So if you have to start a rexis, then there should be something to hold on to complete the rexis. So stain the capsule very well. One thing we can keep in mind is a split capsule in a penetrating injury may not run to the periphery. So many of the cases we can go about with keeping the lens in the bag. Visualization may be impaired. In this case, actually the corneal sutures was on the side, but when the sutures are in the center, the visualization is very difficult. And be ready for tackling any kind of complication in traumatic cataracts. Informed consent is a must in all traumatic cataract. The next case scenario, we'll just see the case what it is. The surgeon has started with a capsular rexis. Nice, well, it is going on very well. When it came to the superior part, see, the AC has just come down and it has just extended to the superior area. The surgeon is now trying with an utrata to complete the rexis. It's not coming out. She's cutting the capsule and completing the rexis. Hydrodissection is done. The nucleus has come to the AC. Soft cataract. It's rotating well, and the nucleus is out. Cortical cleanup is done. And carefully, the lens is placed in the bag. So in this case, the take-home message is adequate filling of AC with visco is very important, because we need space for our capsular rexis to be done, especially in hypermetropes, especially when the cataract is very hard, especially when it is a intumescent cataract or phacomorphic glaucoma. You have to have adequate space in the AC to do the capsular rexis. Make sure not to apply pressure on the opposite side. For the beginners especially, when we are stabilizing the globe from the other side, we'll be applying too much of pressures with our tooth forceps or our stabilizing instrument, and this can just leak out the visco from the paracentesis, and then this can collapse the AC. So make sure not to apply pressure on the opposite side while stabilizing the globe. Do not press the paracentesis with the hub of the cystitome. When we start our cases, what will happen is we have a tendency to, we are just seeing the capsule and we are just doing the capsular rexis. We are not seeing what is happening outside or what is being done outside. So many times we'll be pressing the posterior lip with the hub of the cystitome and the AC just collapse out. If there is an extension, try to retrieve. Don't exert too much stress on the zonules. Gentle hydro in multiple quadrants to prevent a wraparound is necessary. Next case is a black cataract with a poor dilatation. Two side ports are created. Stretch pupilloplasty is done with Kuglen hooks because this black cataract will not come out through that small pupil. Adequately sized pupil stretch is being done. When we are doing the capsulorhexis in this type of cataracts, even if you do a stretch, the pupil may not be that dilated, so you'll have to go under the pupil and do the capsulorhexis. Surgeon is doing the capsulorhexis under the pupil. See, the incision is quite big. It's not 6, it's more than 7. Gentle hydrodissection, tap the center. See that the nucleus is adequately rotating, and we are using a 2-dialer technique to take the big black nucleus into the AC. Adequate visco should be put over and underneath. You can even use visco dispersive underneath. A bit of iris prolapse which had been reposited, and IOL is inserted into the bag. So in this case, in case of hard cataracts, adequate rhexis is very important. Adequate wound size, as already had been discussed, it's very important. If you are doing from the superior part, an adequate superior traction, especially in sunken eyes, is really important. Visco coating of the endothelium and under the nucleus, because you need space for the irrigating vectors or your vectors to go in. You can even use a dispersive viscoelastic so that the iris doesn't get caught on the vectors. No premature entry. Be very careful when you are putting the incision. If there is iris prolapse, prevent what you have. 2 words about iris prolapse. Iris is a very friable structure. Once you irritate the iris, no, it will always be floppy. So it is basically, you should keep in mind that iris should not be irritated. Once it gets angry, it is always angry. So when you are planning a cataract surgery, if you feel you can have an IFS or something on the table, be ready with all the armamentarium. When you are putting the paracentesis, you can see that iris is a bit coming out. Put in a bit of dispersive viscoelastic, keep the iris tucked in, and when you are doing the capsulorhexis, it will be easy for you. Prolapsed iris, reposit it back, suture it well, put in carpinol at the end, and your surgery will go on well. This is another case of PXF with poor dilatation. Should we stretch the pupil? The cataract is not very hard. I've started the rhexis, central triangular flap is created. See, the rhexis is going down the pupillary margin. This is very important. So adequately sized rhexis is very important. Don't judge by the pupil. You have to go under. You can just, what you can do is, a small tip that Dr. Sai has taught me is that you can actually see the iris, that the pupil the capsule going under the iris, and the movement, the wave that can be seen can be judged. The size of the rhexis can be judged from that, and then you can complete the rhexis like that. It is not mandatory that you should stretch all the iris during the surgery. So the take-home message is small pupil SICS is possible. Rhexis should go under the pupillary margin to get an adequate rhexis, cosmetically better pupil post-op. To conclude, every step of surgery is important. From the patient, from the time the patient comes to the OPD, the preparation is done. The surgical management should be in our mind for the particular patient. Surgery is a mind game. Fresh, peaceful mind has more thinking capacity and better presence of mind. Adequate sleep, appropriate homework for difficult cases, Anybody can have complications. So don't hesitate to seek help in case of complications. Ultimately, what matters is patient, their satisfaction and their vision. Thank you.
Thank you. Thank you very much for that great talk.